Do you suffer with headaches? They negative impact your life. They might be chronic, they might be severe. They might affect you from or prevent you from being able to work, enjoy being with friends, enjoy being active. Headaches are probably one of the more common conditions that I treat in my practice. And the importance for me is to recognize when I can treat these or how I should treat these headaches, whether I need to work alongside a medical doctor to assist in helping with these types of headaches, whether or not these headaches have to be sent off to an ER because it might not be a headache that's it actually might be a headache that is an emergency. What am I going to do in this video is I'm going to compare headaches, starting with the most common headache that I treat, which is a cervicogenic headache. I'm going to compare several different headaches to the cervicogenic headache because they are very similar, but they may need to be treated differently depending on what's going on and what the actual diagnosis is. So with cervicogenic headaches, they are headaches that originate from the neck and then refer to the head. So more often than not, when we look at people who have cervicogenic headaches, it doesn't matter whether they're male or females; they occur with the same rates. When we look at when people get them, more often than not, we're kind of middle aged. We're 30 to 40 years old. Within that age, within those 2 decades, we can see it in people who work in sedentary jobs, like office workers, those who have a little bit more active jobs, such as hairdressers, or even more physical jobs, like carpenters, and people who have to sit for long periods of time, like truck drivers, or, and again, office workers are in the same situation. We also see this type of headache often in weightlifting athletes. It's probably one of the top types of headaches that occur in weightlifters. So I'll be seeing these in my athletes along with my office workers and my manual laborers. The most common clinical features that we see when it comes to cervicogenic headaches is that they vary in duration or they fluctuate their continuous pain. So when you're experiencing these headaches, it fluctuates in pain. Typically, the pain is moderate to severe, but it's not throbbing. When we look at a patient's history, we'll see that they may actually have had a previous trauma to their neck. They may have had been in a car accident. They may have fell down some stairs, hurting their neck. And lastly, they'll have pain that may radiate down into the shoulder or into the arm. So these are the most common clinical features, but there are other clinical features that we see. The headaches tend to be one-sided, but they can be on both sides. They tend to start in the back of the head, come up and over into the front. Typically, there are some neck movements or sustained neck postures that can aggravate these headaches. And these headaches don't come on immediately, they tend to develop about half an hour or an hour later. Patients come in to see me, they often say, "Oh man, it feels like it's kind of locked up in here." It's not an uncommon thing to hear people say that. And when I go in and get my fingers in onto some of those muscles, they can be tender, and sometimes they may actually refer to the headache area. I may also see that there's some lack of range of motion in the neck. Patients will say to me that their headaches tend to last for hours or days, so it's a longer type of headache. Uh, if they take if there's an anesthetic that's provided, there will be a positive effect. So a blockade to the area that's causing the pain can be positive. But if you take medication that's typically used more so for migraines, it has a partial response. So there might be an effect, and I think this is why it might confuse people with having a migraine versus a cervicogenic headache. The other thing that kind of confuses you is that some of the symptoms may be very similar to migraines in that we may have sensitivity to sound, sensitivity to light. They may have nausea, vomiting, and they may have some swelling in around the eye. So some similarities there and can be confusing. So let's start comparing the headaches. The first headache we're going to look at is hemicrania continua. These headaches are similar to that of cervicogenic headaches. They tend to be one-sided. They don't switch over. They tend to be more often in females. Similar regions of pain. They're long-lasting attacks. They fluctuate. They're fluctuating, continuous types of pain. Similar to cervicogenic headaches in that they're moderate to severe. They're not excruciating, but they have no effect on neck range of motion. There's no body positions that make it worse. And there's an absolute response with a non-steroidal anti-inflammatory, and very few and moderate effects on nausea, sensitivity to light, and sound. When we look at chronic paroxysmal hemicrania, again, it's one-sided, tends to occur more in females. Again, it's in the same area, but these are short-lasting attacks, and they're sharp, and they're excruciating. There might be some positions that cause it to come on, but they occur very quickly and within a few minutes, compared to the the cervicogenic headache, which tends to be come on about half an hour to an hour later. And again, if we take a non-steroidal anti-inflammatory, there is an absolute response to it. There is definitive improvements that occur, and we will see some type of autonomic signs and symptoms like nausea and sensitivity to light and sensitivity to sound. Cluster headaches are a little bit different. Again, they are one-sided, but they occur more often in males. The pain is again still in this region. It's throbbing though, rather than continuous. They occur in clusters, so you'll have it for a little bit and then they'll disappear. You may also experience redness and watering of the eyes, nasal congestion. You may see that the eyelid kind of droops or there's swelling there, and you may experience sweating on the forehead. Very different to that of a cervicogenic headache. This time, when you take medication that's specific for a migraine, there is a response to it. So there may be some benefit in having take a medication that is for migraines. Migraines themselves, in this case, they are one-sided, but they can shift sides. Females tend to experience this more. The pain is in the same area. And these attacks only last between 4 and 72 hours, whereas cervicogenic headaches last a lot longer. And these headaches also tend to be pulsating, whereas we've got a more continuous fluctuating in pain, but not pulsing. We don't see any effect on neck range of motion. We don't see any effect on body position. No pain that goes into the shoulder. And when we take a medication that's specific for migraines, we get an absolute effect. And migraines is probably the most common one that we expect, that when we see some autonomic symptoms, kinds of symptoms such as nausea, sensitivity to light, sound, visual changes, those types of things, we have those effects. Tension type headaches. Now they're different. Tension type headaches tend to be on both sides, and they're kind of banded around. They tend to be long lasting. They tend to be more often becoming chronic. And typically when we have these bands, it feels like somebody is pressing in and around your head. Unlike that of the fluctuating nature of that of a cervicogenic headache. When we look at range of motion, we see no effect. We see no effect on body position or sustained postures, no effects in pain into the shoulder. And if you take any medications, we won't see any effects at all. And we might see some effects on autonomic nervous system. So the key here is that it's both on both sides, and it's dull, and it's pressing, and it lasts a long time. Not a headache, but something that's important to note is occipital neuralgia. Now, occipital neuralgia, there are nerves in the back of the skull. There is the greater occipital nerve, there is the lesser occipital nerve, and we have the third occipital nerve. And these headaches, and the reason I'm looking at this is because cervicogenic headaches tend to start in the back of the head, and so it's important for us to differentiate between these two headaches or two pains. These headaches tend to last for a few seconds to minutes, so they're not really long lasting. They tend to be lancinating, sharp type pains. So it comes on quickly, lasts for a short period, and then they disappear. It may be affected by neck movement because the nerves that are irritated, the muscles that go up into our skull, those nerves pierce through those muscles, and that may be why we get that pain when we move our head. When we go into the nerve and when we feel the nerve, and I see this often in my patients, there's pain in that area. We may also see with this type of headache is that there may be some trigger points to the shoulder and trapezius. So we got some similarities to cervicogenic headaches. And then when we take some type of non-steroidal anti-inflammatory, some type of antidepressant, serotonin, norepinephrine reuptake inhibitors, or even anticonvulsants, those tend to help. So in this case, when I see somebody with this type of problem, though I may be able to help out with the muscle area to help relax some things, a prescription from a medical doctor may assist with helping out with occipital neuralgia. Now, it's also important to realize that there are other conditions that might actually be causing your headache. The ones I see are the ones that tend to be that I've talked about, but these are other important ones that are important. There may be vascular issues, such as a giant cell arteritis. Arteritis. There is an aneurysm. So if you have a stroke that's coming on, that might be that versus your headache. So we have to be very aware in our practice to think beyond this is muscle and joint and nerve. Speaking of nerve, there are neurogenic type causes. There could be a radiculopathy, an irritation of the second cervical nerve. There may be an infection as well. You might have multiple sclerosis and other neurological conditions. We may see irritation from arthritis. A person may have a condition where the bone is being broken down, an osteolytic lesion. They may have a subluxation of the vertebrae, between the first and second vertebrae. The person might have rheumatoid arthritis, or they may be experiencing what's called is a Arnold-Chiari malformation. They may be having meningitis. They might have shingles, and an interesting one called neck-tongue syndrome, where when you press on the area here, the tongue actually goes numb. So there are other things, but they're not as common. So there you have it. There are your comparisons of different headaches compared to that of a cervicogenic headache. So if you're experiencing headaches, realize that what you think might be a migraine or maybe coming from your neck, there may be other conditions that might be contributing to this, and the appropriate diagnosis is required, referral to the appropriate practitioner. So if there's something that requires a non-steroidal anti-inflammatory, some sort of antidepressant, medication for migraines, then this is where following up or working alongside a medical doctor is important. Dr. Notley, Winnipeg chiropractor and athletic therapist. I hope you found this interesting.